here for. Yep. More than that, right? What else?
Different effects depending on how it's administered.
Okay. So that kind of gets back to that current care versus interior that we're talking about, right? Good. What else?
Sixth, right?
Good. Talk about that. What else? Yeah. So one of the big deals about you is that if you want to know part of that lawsuit side as to what you can get sued for, this is one of them. This is one that can get you into a whole of issues outside of just narcotics that we talked about in the last hour. What else? The right way, wrong way to do it. Okay, six right, we talked about that. We'll talk about that. What else?
Fast medications as well.
Okay. No. Do you need to know drug doses for this?
Yes.
Yeah, so the idea that you're going to get several different sides to that, figuring drug doses along the way starting next week. You need to be good in terms of identifying where the drug is and how it works and side effects to it. Absolutely. So everything that we talked about last hour has a bearing on this as well as far as the different medications along the way. So as we start talking about the different things that we use, the drugs that we use, and how we use them, is kind of an extension of what you're going to talk about. So we're gonna talk again about 6 rights of drug administration. We're going to understand how to draw medications from ampoules, vials, and non-constituted vials. We'll talk about that. Talk a little bit about subcutaneous versus IM versus IV medications, and then finally IV drips. This goes to what I just got finished talking about, the idea of the Trinity protocol as far as the drug, as far as knowing when to give it, how to give it. The best way for measuring afterwards is to have that few patients, is what we're talking about. The medication is given as a verbal order, you repeat it back to the doc. So if you call medical control and you want to know about medication X, and they tell you to give 75 milligrams of fentanyl, you're going to read back to them 75 milligrams of fentanyl? Are you sure you really want me to give 75 milligrams of fentanyl? No, I really want you to get 75 mics of fentanyl, right? So the idea is to read it back verbatim to what they said. And then write it down in terms of your documentation as well.
Doctor insisted he wanted 75 milligrams. So.
Each order, listen to this, each order needs to include the medication desired, the dose desired, the administration route, and the administration rate. All 4 of these are part of your 6 rights. So next week, as you're starting in drug doses and everything like that, Doug will dive deep in terms of knowing about the medication desired, the dose desired. So it reminds me, starting tomorrow, I was going to put it on an email this weekend, but starting tomorrow, I want you to bring glasses in. If you don't have glasses, then we'll give you a pair tomorrow, no big deal. But if you have them, bring them with you. Starting tomorrow, from here on out, we wear glasses in terms of all of our labs. So everything we do is going to be about BSI. So we start playing that game here so that you play that game well out there. Hand washing is important yet again, but nevertheless, it's going to go away. So the idea in terms of more so the idea in terms of using needles and sharps and everything else like that is a primary way that we end up with a problem with us. And so one of the things that has happened in the industry over a period of time is that we're getting further and further and further away from using needles and sharps for giving medication. When we talk about needle and ports, we're talking about the fact we're trying to prevent this right here. I got to tell you that I've been very, very fortunate about this, but the idea of bumping down the back of an ambulance trying to the needle somewhere in your hand, that is a certain great concern. The idea in terms of whatever medication that you're going to give, there should be an assessment that goes somewhere along with that in terms of why you're giving it, not just giving it because. The idea in terms of a medication error can have a greater effect than you and I know of. The idea that it can have profound effects on your patient somewhere along the way. If you're talking to medical control, or when you're talking to medical control, determine what drug it is that you want to give that's close to your scope of practice. Confirm the order again. We mentioned this a couple of seconds ago. The idea in terms of going back and repeating the medication, the dose that we're talking about, and the route that you're going to give. They will not. In most cases, medical control, depending on who they are, will not know your protocols at all and not have a clue about your protocols at all. So again, that's worthy of the fact that you're going to have to go back and repeat whatever it is that they want you to give. If you have to desire, and in many cases, you don't even have a drug to begin with. And so you're going to have to correct them about it. Write down the order and the time of the order. Proper medication, check the name of the medication. So get this. You should be into a habit, especially if you have, if you're doing paramedics on a apparatus. The idea that you should do a check for whatever medication is along the way to verify that you're indeed giving the right medication and the right dose. And this is one of the ways of trying to correct medication errors along the way. Oh, by the way, there's a research study out there that shows that we as a profession, when I say profession, not just EMS or fire, we as a profession, I'm talking about the medical community as a whole. There's a research study that was done about a year and a half ago that indicates that probably somewhere around 15 to 20% of the time, we're making medication errors. And so to that, the idea of one of the ways of getting around that is asking your partner to verify what the drug is and the dose along the way. Here's your rights. No. So in our world, to where we're only taking care of one patient at a time generally, this probably is not going to be a problem, right? Will the right medication sometimes be a problem? So we were talking, I was talking with Alice during the break, and we were talking about that we wish that all drugs had a different label to them so that there was a clear distinction about one drug versus another. So unfortunately, there's a number of different drugs out there that have almost the same type of label that you have to look very, very closely for. The opportunity for us making mistakes based on this right here, especially when we're in a hurry, especially when we're under a whole lot of stress, very, very easy to happen. You're tired, you're going to sleep, and that's the thing. It's a setup for the possibility of medication error based on that. Right dose. The idea that overdose, underdose, and especially what population are we talking about right here? Peds, especially when you're under the gun as far as taking the right dose along the way. And so to that, again, very, very common issue. Right route generally is not going to be the big issue because, like we talked about earlier, that a lot of the drugs that we're going to end up giving is going to be with IV bolus. Right time. How might right time play in it?
Time between.
Yeah, exactly. The idea that you're supposed to get epinephrine every 3 to 5 minutes, and you choose to get epinephrine, 2 epinephrine back to back with each other. Probably not cool, right? And so to that, a number of different ways that can happen.
Also, expiration date on there.
Yeah, absolutely. And so while it's not here for expiration date, the idea in terms of that usually is covered right here. What do you want to document?
Everything.
Yeah. Are you going to document that you cover the 6 records with them? Maybe, but usually that's going to be assumed. What are you going to document? Time. There you go. So what happened in terms of the follow-up to whatever that drug was along the way, right? And so each and every time that you get a new drug, there should be something along those lines that kind of documents that. Now, let's get honest. In a cardiac arrest, how great are we in terms of documenting exact times for our drugs? Sometimes okay, sometimes not, right? So the idea in terms of being as close as you can in terms of wherever that drug might be along the way.
Yeah, I think monitors have like a button on it.
Yes, they do. If you're thinking about that, yeah. All right, so from a three-helical standpoint, we talked last hour about parenteral. This is another way of looking at that. So transdermal administration, sublingual, subcutaneous, IM, IV, endotracheal administration, IO, and maybe rectal as well. We talked about this last hour, so I'm not going to hang out here, but just a reminder, the idea that with enteral, it passes through the liver, slows it down as far as being digested throughout the rest of the body. Where parenteral is going to initially bypass that and then come back to the liver over a period of time to be broken down. This is just a slide that shows the advantages and disadvantages of both, and so you don't need to memorize this per se, but you just need to know the difference between the two of these. We talked about enteral, we talked about oral, we talked about oral and nasogastric, talked about sublingual. Again, check this out. Sublingual falls under this as well as this. So it depends on what the drug is, depends on how well it's absorbed. What's buccal? In the cheek, right? What do we give buccal?
Glucose.
What was that?
Glucose.
Glucose, right. So glucose gel, right? And so the idea in terms of buccal, there's a number of different drugs out there outside of that, but it's probably the most common one that we talk about. And again, depending on what the drug is and everything else like that, rectal may be enteral, rectal may be parenteral. It just depends. So this right route, the vast majority of medications EMS is going to be with IV push. Kind of talk about that already. Always be sure that the speed at which you're pushing the drug is going to work well for your patient. Let me give you an example. Narcan, wonderful drug, and especially with all the narcotics that's going on for overdoses and everything else like that. What happens when you give Narcan too fast? Yeah, well, they may come up swinging, but there's something that's even as bad as that. So the bomb is coming up with the swinging at the same time. So the idea in terms of speed of medication is a big deal. Let me give you another one that you may not know about. Lasix. Lasix. We use Lasix for what? It's a diuretic, right? So we use it kind of like for congestive heart failure, although not nearly as much as we used to. So Lasix, you give it too fast, and especially in the geriatric population, they have tinnitus. You know what that is? Ringing of the ears. Oh, by the way, it can be broken in. So us pushing Lasix a little bit too fast along the way can create hearing loss in the geriatric population.
How does that work?
As far as the tinnitus, yeah. it has a sensitivity in terms of hearing per se. Past that, I would have to look for that for the rest of the story.
Yeah. My wife was just reading an article about issues with Lasix being, I don't remember exactly what she's telling me, but something about pushing it in a CHF patient and essentially causing them drowning rather than pushing it out.
That's awful nice, man.
Thanks, Dad.
Go to service. That's pretty cool service.
That's what we do. The only way to go hungry.
So I have not heard that. And that kind of works. That kind of works opposite from what Lasix normally works at. So yeah. I have to look at that.
I can see if I can get that. Hold on.
They bring you your slippers also?
What's that?
They bring you your slippers also?
I wish.
Nice. No pillows here.
Rub your back?
All right. So again, route and speed, big deal. So here's the other thing. You're going to have some drugs that you can give IM versus IV. A good example of that would be Benadryl. You can give Benadryl IM. You can also give an IV push. Does it make sense to give them a shot when you have an IV in place for Benadryl? Probably not, especially if you have somebody with a true allergic reaction. But nevertheless, you can give it a couple of different ways depending on what the drug is, you know, like that. So decision in terms of best interest for your patient. All right, so we are going to talk about ampules. We are going to talk about single and multi-dose vials. We're going to talk about non-constituted syringes. We're going to talk about pre-filled syringes, and we're going to talk about intravenous medication fluids. So back to our 6 rights again, the right documentation. We talked about this already. Talked about, in terms of every medication that's out there, especially the ones that will be in your hand. You have, for example, epinephrine injection, 1 to 10,000, 1 milligram, glass Allergen, expiration date, and it's going to have the content in terms of what's in the syringe itself. Okay, so 1 milligram is 0.1 milligram per milliliter. So the idea in terms of each one of these labels will be a sub. So let's talk a little bit about glass ampules. So glass ampules are by far going by the wayside. Okay, it used to be that epinephrine 1,000 would be like this. Okay, and I will send this around for each one of you to take a look at. This is pretty much gone by the wayside in terms of epinephrine 1 to 1,000 in this concentration. So to that, you will sometimes see fentanyl in ampule as well. But typically, in most cases, we would go into vials versus ampules. Why is that?
There's a little more risk in those. You cut yourself, you get the
Yeah, so the idea in terms of shutter, the idea it's got, if you can't see it from where you're sitting, the idea it's got this blue line around it, the idea that you're supposed to break off the thing there. I don't have a 2x2 here, but the idea that if you had a 2x2, you would end up wrapping around that and just break off the neck of it there. Okay. The bigger problem is not only that it's going to create issues for you, but shards are inside of that epinephrine now. And so that's one of the reasons why in the pre-hospital side, we've gotten largely away from using ampules along the way. Nevertheless, you're going to see them out there. And so to that, we're going to start talking about that once we break off the neck of this. There's something that's called a filter needle. So filter needle is exactly as it sounds like. It's got a small side in terms of drawing up, but you can't draw up any shards as far as your syringe goes. And so you're going to get rid of your medication there. You're going to break it off. You're going to attach your filter needle to your syringe. You're going to drop your medication. And then you get rid of the filter needle at that point. You go to a regular needle, or hopefully you go to a needle assistant where you can just push this.
So, Gary, just a side note. So that's what AMR, if you guys are ever in one of our boxes, that's what AMR is providing us now for Epi. So,
we've got a bunch of boxes with them, but we've got one for them.
well, that's the pre-filled. If you look there, the 1 to 1,000, that's what they're providing us. That's what
Are you
AMR
using
finds
ampules or
us.
using rods?
We use ampules.
Yeah.
Yeah.
Really?
Yeah.
Our
It's
hospital
25%
keeps running
cheaper
short
here.
on Epi, and we keep the ampules as well.
Again?
Our hospital that we supply from, keep running short on the boxes of Epi, so we end up getting the
Right.
ampules.
Right. And that's going on with epinephrine right now. 1 to 10,000 is in huge supply, short supply. So the idea that it is going to 1 to 1,000 means you have to draw up your own. So that being said, how would you do it?
I don't think that's why.
So you draw up 9 cc's of saline. You draw up 1 cc from this right here. Okay, will equal 1 to 10,000 at that point. So it doesn't matter if it's ampule, it doesn't matter if the vial. It's the same thing in terms of 1 to 1,000. We'll get you that 1 to 10,000. So carry that the rest. The unfortunate side, if you're carrying ampules, it's that much worse as far as trying to draw that up.
We actually have
We
to
have-
do that.
We have boxes that are like that too.
Where we run out of the pre-fill it, so we have ampules and filter needles and
Already
flushes all
filled, yeah.
taped together, so we
Yep.
can
Stop.
Don't freak out if you guys don't see it, but that's.
You know, our Epi kids are,
All right. So the idea in terms of sometimes, every now and then, I haven't seen it recently, but every now and then you have a kit that kind of comes prepackaged this way. When would you use 1 to 1,000 typically outside of cardiac arrest? When would you use 1 to 1,000 epinephrine? Right. So the idea that many have gotten away from auto injectors for epinephrine, have gone through this because of the cost of it, right? So that's the other way you see it. And sometimes you will see it in the patient population, they're not carrying EpiPens, but they're carrying this. Sometimes this is the way that you'll see this kit as well. So there's a line, we identify the drug, we identify the expiration date on it. Take a 2x2 and we're going to break it off of that neck. You're going to draw up your medication. In this case, if we're only using epinephrine, we can use a 1 cc syringe with a small, they're not even using a filter needle here. So you would end up using a filter needle again, like we talked about. Questions to that? You're going to get your hands on this starting tomorrow. And so I'm not going to camp here, but just kind of describe it and go from there. All right, so vial. So much nicer, much easier to use in terms of advil versus vial. So vial, same thing. You're going to end up looking at your medication. You're going to end up checking expiration date. You're going to make sure that you got the appropriate dose that you're going to go for. And so sometimes with epinephrine, you might end up pulling up 2 different vials depending on what you want to get along the way. And so have the appropriate number of vials next to you. They're showing naloxone. So you got 400 mics per mil or 0.4 milligrams per mil. Now this is a multi-dose type thing of naloxone and would be much more than the maximum dose you end up giving. And so you got 10 mils right here. A maximum dose of naloxone or Narcan would be 2 mils. So same thing. You do not have to use a filter needle with a vial. And so you're going to pop the cap on this. You're going to take a appropriate size syringe. So if we're talking, in this case, we're talking about epinephrine again. It holds 1 mil. So you end up using 1 mil syringe with a needle. You're going to pop the cap on it. You're going to hold it up in this direction. You're going to end up pulling out where the drug is. Now check this. There are some that will say you drop all the medication into that syringe. There's others that will say you just draw whatever dose you want to give. There's a couple of different ways of doing that, and we'll start playing with that tomorrow to go into a little bit more detail about that. Okay? The other thing that you can do is that prior to sticking this into the vial, you can pull back on the plunger as far as the amount of air that you're going to use and squirt that into this, and there's a vacuum on that will create that medication start coming your way. Okay? And they're just cleaning this with alcohol prep. If you have a fresh cap on it, you don't necessarily need to do that, but any time that's been sitting, like the thing that put an alcohol swab on top of it. And again, they injected air into this. They're pulling back as far as whatever the dose is. So non-constituted drug. What's one of the non-constituted drugs that you will carry? Glucagon, right? So it's non-constituted because what it has is it has a powder on one side, it has liquid saline or water on the other. Okay, glucagon is probably the most common one that you'll end up having a constituted one, right? Not the only one, but the most common. And so the idea is much the same thing. It's a vial, so you're going to end up pulling up your water or your saline on one side, injecting it into the powder form, swirl that around a little bit, and start pulling back your glucagon. Okay? Same thing in terms of how you draw it up and move it. Questions to that? Yep.
So Solomedrol is like.
Yeah. So Solomedrol is a little bit different in terms of sometimes how you see it. So what you're talking about, what she's talking about is that you can actually break it in half. And so the powder form is on one side, the liquid's on the other side, and so you just end up pulling it that way. Okay, so yeah, good example of that. And that's exactly what Bethany was just talking about. This is a good example. This could be glucagon. It could also be Solomedrol, a steroid type thing. And so all you're doing is you're taking this and you're actually mixing it into this and just drawing up a little. So rectal administration, and these days we've kind of gotten away from doing rectal administration. Thank God. But it used to be, and it still can be, and especially in your patients at home, that the physicians would tell them, providers would tell them that rectal administration works very, very well for you, and it truly does. It works extremely well because it gets in the bloodstream very quickly. But the idea in terms of how you administer it, how you control it, and everything else like that, is the bigger issue in terms of how you're going to do that. You drop the same amount as you normally would. You end up putting, you take a plastic portion of the IV catheter, and you can administer it with that. You can also take a small ET tube, like a 4-0, 5-0, something like that, in terms of just attaching it to the syringe, and you inject it about an inch into the rectum and just push your medication. The kicker is that because of that you have to hold the cheeks together in terms of rectum, otherwise it just kind of spilling back out. What's the story? I'll think you didn't want it.
Probably a lot.
I got it. Yeah. I'm telling you, the good old days were not so good.
Do you pull their pants up with your top?
All right, and that's exactly what I was talking about. The idea that it's not nearly as controlled because of all that we're talking about. What has replaced this largely is what? I'm not sure I am. IO. So back in the day, where you could not get a line or anything else like that, this was Plan B. So the idea that's been replaced by IO is the next best thing. But let me just tell you, because you're gonna see this, and especially in a home setting, you're gonna see this to where families have been told that to administer rectal diazepam, especially, probably most common, is something that you're going to hear about and see with your patient population. And that's exactly what I was talking about. The idea that this is just a plastic portion of the IV needle, and so you just got to pull up your drug and administer it that way. And this is an ET tube, the same thing. Transdermal. So transdermal is what? What do you likely to see transdermal?
Like paint patches.
I'm sorry, say it again.
Your paint patch. Yeah.
Okay, such as what? Fentanyl is probably most common. What's another one?
Nitro.
Nitro. Good. What else? Nicotine. Good. What else? You're going to line close.
Like paint, like, I don't know, Bengay,
You can see it in terms of patch. You can see it on the skin.
well, I've seen it like the hot ice.
Oh yeah. So like Shaq is never Tylenol patches is there. What else, folks? What's that? Yeah, burn patches. Okay. What else? Birth control. Yeah. So the idea that patches are becoming more and more common every single day. Now check it out. The idea in terms of your patches will look something like this. Okay. So they will have a name on it. They will have an expiration date on it. They will have the dose on it. Okay. So unless you're kind of into it, the idea that where do most of those patches end up at, especially pain patches, where they end up at? On the back. Why?
Large muscle man.
Yeah, that's part of it. The idea that they absorb very, very well through the back portion, especially as your patients are lying on their back, the blood will circulate in that area and work fairly effective.
Is that also because of less adipose tissue?
Probably in some cases it can be, yeah. So what's the downside to all that?
They get multiple.
Yeah. What else? We miss it, right? And so the idea that you can't figure out why this person's unconscious and barely breathing along the way. So they just took one fentanyl pill about 4 hours ago and pull them up. Take a look at the back. That's where you probably do most of the fight. If they tend to be abusing along the way, that's the other place you will find it. So I found this is really crazy place as far as assessing your patient. Yeah.
Medication pumps.
Yeah. So what population would you see there? So those internal hospice type patients will be on pump along the way. So again, it works very, very well. The idea that we're going to do much with pumps, not so much. But the idea that we can do something with patches is certainly a possibility. By the way, how does nitro work in terms of crossing the skin? Why do we have it in place? Do they always have chest pain? Ever thought about that? Say again?
Vasodilator.
It is a vasodilator, but why would it always be in place? Why would you have a patient with nitro patch in place? It truly is a cumulative effect. That's a true statement. What else about it? Why would you have a patient with nitro patch in place?
hypertension.
Yeah, that works well, a number of different sorts. Certainly hypertension is one of them, but there's something else about it. These patients, exactly, that's it. These patients with angina, where they have this chronic angina going on, providers in many cases will say that you have X number of cases of angina in X amount of period of time, you put a patch in place.
So it's electrical.
Absolutely, absolutely. So instead of taking that pill and have this up and down effect, that nitro patches will work very, very effectively in terms of crossing that skin barrier into the bloodstream and work slowly over a period of time. So while you don't have this huge 0.4 milligrams of nitro effect, you have this nice steady effect in terms of the adjustment going on. That's the difference. That's why you can see it twice.
Don't you just end up masking an underlying condition?
You may. But again, your patients are going to know that if they break through based on the patches and everything else like that, that's when you get caught at some point.
So are we able to take these off?
Yeah, absolutely. Absolutely. In all cases, the idea of removing patches is something that we're going to talk about with assessment. If you don't know what the patch is, you should all know in terms of small print. Okay. When I developed this, it was just one of those things. I know that it's small print every time that you're looking at that patch to identify whatever it is. But if there's any doubt in your mind as to what that patch is or what it's doing or anything like that, pull it off. Yep.
Just something that kind of on topic that happened recently.
Yep.
In a nutshell, I wasn't there, but there was a call for VA Alpha out of one of our facilities in the city. And they found this guy and he was acting really weird. He'd driven his truck through a fence out there. And his behavior was weird, but he was so conscious and wasn't able to talk. Well, they sat him down and assessed him, and basically found out that he was under the influence of opiates. And he had done that, I can't say where he worked, but at a facility where he had access to recycled or disposed of medical equipment, and it was a fentanyl patch, and he was chewing on one that he had picked up. So it's really easy to hide that behavior.
In terms of abuse of it, it's crazy as to what you're hearing about. Chewing on it is one. Taking a syringe and drawing it from the patch itself is another that you hear about.
Can you really do that?
Yeah.
Just squeeze it or what?
Yeah, you end up squeezing on the patch itself. Absolutely. You'll hear about that. So yeah, there's some crazy things out there as to what's going on.
It was very easy to conceal. In other words, you'll never know. So that's a popular thing.
So by the way, my all-time record, and I'm sure there's some that have more, but my all-time record in terms of rolling somebody over on their back and finding 5 fentanyl patches is my record. Like I said, there may have been more. Some of you may have experienced more.
I was going to say, I've heard stories of grandpa who's got fentanyl patches that lost one, put another one on, went back to bed, rolled over on it, and still a couple of those.
Yep. And then they wonder why they're unconscious. All right, G2. So here's Gary's opinion, and I'll give you the official version as well. In Spokane County, you're not using OG2, you're not using NG2. In Gary's opinion, you should be using OG2 and NG2s, okay? Not for pushing medications, but in terms of drawing off contents from the gut. The idea that in the cardiac arrest that 9 times out of 10 they've had pizza and beer just prior to you, and now all that stuff is sitting in the gut, that it wants to come out in some way. The idea that you can make a difference as far as drawing off content of the gut is what we're talking about. Nope.
Is there discussion to make it
So let me just tell you, I tend to feel fairly strong about it. So it's one of those things that I'm trying to push along the way, but at the moment there's not a whole lot of thing. Is it in your protocol? Yeah, I thought it was. The idea of you can make it different in terms of NGO2, it just isn't here right now. Okay, so you are going to get signed off on it here. It is in the skill sheet that we're going to walk through and everything like that. The bottom line is that it's very easy to insert as well.
What step in the intubation process, Gary, is that? 'Cause I don't have any.
It's afterwards. You get two in place, and you start working through a secondary type thing. You put OG and NG2 in place. If you go to the hospital, what's one of the first things they end up doing?
That's what I just had your thoughts on.
That's what it is, it's a certificate.
And this is what this guy's going through right now. So what has happened prior to you even knowing about this is they've measured between, this is going to be an NG2, and so they've measured between the nose, the ear, to the middle of the gut, right? And that's how much they're going to push this tube down. And so they should have taped it somewhere along the way in terms of the depth of it and everything else like that. And so truly, it's uncomfortable, especially if you have a conscious patient. Truly, it's uncomfortable in terms of you have to get them to swallow to work with you along the way. Most will not do that terribly willingly, but it makes a difference in terms of unconscious patients as well. And so she's just inserting this into the nose. The other thing that you can use that takes away some of the gag on this is some lidocaine gel, and that just kind of numbs the back of the throat. So, in this picture, she's actually pushing something in terms of this NG2. So the tube that I got up here does not have this port that goes off the side of it. The tube that I have up here is just strictly for pulling off aspiration from the belly. Yeah.
There's a video from last year's concept.
Yeah, as a matter of fact, Strickland is the one that helped also comment with that, and that took one for the team.
Yes, smart.
Yeah, so you're
You can't pick. All right, so this you know about, this you've experienced, this you've been around, and everything else like that. And so MAD device or nasal atomizer is a great invention. I wish that my hand had been on this as far as bang along the way. It works very, very well, right? What drugs can you push through MAD? Okay, you should know this. You should know that Versed, you should know that's Ativan, you should know that's fentanyl, you should know that it's Narcan. Why not epinephrine?
That just sounds like a bad time.
That should be a great time, but there's one thing that holds it back.
Gets to the brain too fast.
All this is about volume, folks. You can push no more than 1 mil. Max is 1 mil per nair. Carefully drawn. So whatever you're doing as far as that drug, it's max of 1 mil per nair. So you're going to come to experience the fact that lorazepam or Ativan is a very thick type of drug to draw up. And yet, you can mist it through the MAD device fairly well. The whole thing about the MAD device is that it's designed to create a mist. And so as it goes up in the air and everything else like that, and you push it in, what you're going to have is this little mist. And because this is so great generally in terms of blood supply that sits right about here, it goes into the bloodstream very, very quickly, almost as quickly as an IV push. That's why it's considered to be a parent care type movement. Okay. Let's see if this plays.
So the MAD device is also kind of a new.
I would say that probably within the last 5 years or so, that is when it first came out.
But it's also kind of a new rectal administration thing. It's kind of helped push that away.
Oh yeah, that's one more small way that it has.
The LNA MAD nasal is the safe and painless way to deliver medications directly into your patient's bloodstream without an intravenous line. To use the MAD nasal, fill the syringe with the proper volume of medication and connect the atomizer. Place the MAD nasal gently but firmly against the nasal opening and briskly compress the syringe plunger. The medication exits the tip of the MAD nasal as a fine atomized mist, resulting in broad coverage of the nasal mucosa with a thin layer of drug. The medication rapidly absorbs across the mucous membrane into the bloodstream, as well as directly into the cerebral spinal fluid of the brain, avoiding first-pass fatalities. This achieves medication levels comparable to injections. Once in the bloodstream, the medication circulates throughout the body. In the central nervous system, it enters the brain and binds to neural receptors, exerting the desired clinical effect. and leading to resolution and improvement in the patient's symptoms. Mad nasal allows for exact dosing, is titratable to effect, and can atomize in any position.
Is it going to reach brain quicker than IM?
Yeah, it definitely will from an IM. An IV, it's just about as fast. And in terms of research, it shows just about as fast. But what's the maximum dose again? 1 mil per nair, yes? Yeah.
When we've
Yeah.
done that in the field, it seemed like it's taken a while. The other thing is that they've done it twice.
Yeah.
And they've become congested. So we didn't know if they were losing most of the medication because it was
So as you administer it, let's suppose that you're going up this nair. It's kind of like the same thing with the rest of the thing. As you administer it on this side, you're closing off the nair on this side.
Yeah. Well,
But typically past that, you may need to hold it closed for a couple of seconds while it starts floating across the bloodstream. But past that, it should not be dripping out.
Also, another thing of those is typically if you don't actually put some pressure on it, it won't happen. So it'll kind of just drip out.
That is for Ativan. For the rest of it, typically not so much. It will administer fairly quickly. But Ativan, you're going to have to push on in terms of pressure. My experience has been that the rest of it is very
this one, I'm not the one who pushed it, but the mechanic pushed it. It took a while to take effect, and then we gave it again. They talked with fire and the third experience. They said it's easier in the field to give it IM.
I don't know. I like me to have my had pretty good success with it. All right, so the difference between a inhaler versus a nebulizer is what? That's not
One is a single action, and
Right.
one is continuous.
right. So the idea in terms of a DUNAB can be a buterol by itself, can be a DUNAB, can be tribulin, can be a number of different things in terms of inhaling. What's the good news, bad news about this? They are easy to use, so that's kind of the good news. What's the downside?
They're easy to lose.
The patient uses them.
Say again?
The patient uses them a bunch of times before you get there.
They can be. Sure, yeah, okay. Do all your patient for the millions that are out there with inhaler, do they know how to use it? I bet because the respiratory therapist right over there, he'll tell you a number of times you've seen poor applications for patients using right? So the idea in terms of just because they use it 5 different times, does not necessarily mean that they use it correctly along the way, right? So so there's that. You've been using this already, you've been helping with this in the ENT. And what about a NEB treatment? What can you NEB? Albuterol, tropium, DUNAB, again, racemic acid, good. What else? There's something else. Yeah, normal saline with what? 1 to 1,000. Okay? So something that doesn't get taught about all the time is that you can nebulize 1 to 1,000 epinephrine with this. You have to put a little bit of volume in there in terms of getting it, but the idea that we're very, very effective. There is a little bit of discussion going on about using 1 to 1,000 epinephrine versus racemic epi. And truth be told, there's not a whole lot of difference. And Josh, correct me if I'm wrong. There's not a whole lot of difference between racemic epinephrine along the way versus 1 to 1,000 epinephrine.
It's just supposed to have less side effects.
Right. So how do you administer it? How do you administer a NEB treatment?
An oxygen bottle with that, put the medication in the chamber beneath it, so it rises into the spout.
How much do you run your oxygen at? Yeah, about 6 liters is correct. Okay, and how long does it take to nebulize in? Somewhere between 5 and 7 minutes. And so the idea of following along with assessment of your patient afterwards would be obviously the thing that you want to get. What side effects would you expect for NEB treatment? Tachycardia, right? Tachycardia, because of the albuterol that's going on, will create that. Epinephrine obviously the same thing. Racemic epi is something along the way. But But I will tell you, and we'll get deeper and deeper into this as we talk about pulmonary later in life. The idea in terms of the tachycardia, while it's expected side effect, is kind of the gauge that some respiratory therapists and some doctors use as to how effective, how much you're going to use along the way for NEP treatment. So sometimes you come back for one NEP treatment, the next NEP treatment, the next NEP treatment, until you get the heart rate to a certain rate.
What else happens in the body with that tachycardia? Because I know it's not just the tachycardia, like the heart rate goes up. I know.
So it's a sympathetic side, so it has effect on the sympathetic side. So think about everything we've been talking about from the sympathetic side. So it's going to cause vasoconstriction along the way. It's going to cause tachycardia, tachypnea. It's going to do something in terms of your pupils. It's going to do something in terms of your lungs. So epinephrine and albuterol have effect on the lungs as far as the alpha and beta effect. And we'll get into that next week. Yeah.
Some people just pour albuterol straight down the UT tube, and some people like to do an inline there.
So there's a question. So Josh, what's your opinion? Epinephrine, or excuse me, albuterol down E tube. Or is bag?
I haven't seen it actually done in the hospital. I've
Yeah.
heard about it a couple times.
Yeah.
I've heard it's very, not usually very effective.
Yeah, and so it makes logical sense, Craig, that you're going to put this down the ET tube, you bag it around, and you can suction it back out over a period of time. That makes logical sense. There's been no science that I know of, anyways, that supports the idea that it's be more effective than nebulized.
The problem is you got to think about that tree,
Right.
all those little branches,
Right.
and if you inject a little liquid, you're getting, maybe down one branch.
So
you're
you're-
not opening the lung.
Your tidal volume is going to limit you in terms of how effective it's going
So
to
in
be.
that case, would you suggest doing it with an inline neb in conjunction with an EPI?
And you can set it up that way, yeah.
Is there an advantage or disadvantage of using the med mask versus the two, or is it just kind of paramedic preference?
Gary's opinion only. If my patient's incapable of holding that, or if they're just not willing to put it up to the mouth with a tube type thing, then I usually will put a mask on and we'll see how it goes.
Do you lose any of the?
Not that I know of.
So yeah, you got to remember your nose is a filter. So not when you put the mask on, the patient breathes in their nose. And so it filters a lot of the medication and stays in there to get down to their lungs. If you get them to do a mouthpiece, then they're going to have a better effect. Some patients though, they're like, oh, I don't want that. I would use the mask. So,
But and Matt too, that usually I won't do that unless they're just not willing to hold it or auto level of consciousness or stuff like that. There is that as well.
They're talking a lot, then the mask actually works better.
Yeah.
It stays on.
All right, so that just gets to what we talked about. Albuterol, typically with a dual neb and albuterol and ipratropium. Why do we usually limit ipratropium to just one dose in the pre-hospital setting?
I've heard it could dry you out
Yeah.
too much.
Yeah, and so theoretically, that's the deal, especially with pediatrics, that it will over-dry secretions along the way. I would tell you that there's been cases where I've used these two doing them back to back and had pretty good success with it. But I think from a safety standpoint, the reason we only do one ipratropium is because of that. So Craig, this gets back to what you were asking about, the idea you can set it up that way in line, that you actually bag it in off of net treatment. The problem is this gets kind of honky, the way that you end up bagging this into place.
I've seen, unfortunately, where someone comes in and they obviously didn't have the right piece.
Right.
They didn't know what piece to use.
Right.
Because it's something you don't do very
Right.
Something to know.
So we've been talking about this, and so by now you should understand this in terms of what makes up a parenteral route and the fact that it bypasses, especially the liver. Subcutaneous. So the idea in terms of subcutaneous versus IM, let's go there. Subcutaneous is typically these days used for what? Only. And so, yeah, and again, you get protocols in that way. But typically these days, if you're giving epinephrine, it's going to be sub-Q. Now check this out. while I say that, the other side of my mouth will say that what we are moving to, what we're transitioning to, is even when we end up giving epinephrine, we give it IM. So I know I'm confusing it, but listen to me. The idea that while a book will still show that you give epinephrine sub-Q, what we will be pushing towards you to do is IM.
Actually, I have a question. I'll read the book and we'll talk about the that's not
Yeah. So it's very confusing. That's why I'm bringing it up now so that see if we can't clear the air about it. So you should know this. Anything that we give sub-Q is limited to 2 mils. 2 mils only. Typically, that's going to be in a deltoid, but a max of 2 mils. And so there's a number of different places, especially for insulin shots, a number of different places that you can end up using sub-Q injection sites, to include the deltoid, to include the abdomen, to include the lateral sides of the alcohol rep. I'm going in at an angle. We're not pitching up that skin with the sub-Q. We're just sliding the skin. And so you go in, you pull back slightly on the plunger, make sure that you haven't hit the vessel along the way. If you end up seeing blood along the way, then you would pull back on the needle and do it again. You end up giving your medication. You're going to then assess your patient, reassess your patient, follow up for that. So 45-degree angle.
Without pinching, is it really easy to go IM?
Typically not if you're going 45 degrees. You're not going to get there. So IM. You're going to end up using somewhere between a 21 and 23 gauge needle, which is about 3/4 of an inch to about an inch in length. You're going to pull up your medication that I've been talking about. And there's a number of different places. You need to know the slide. So bottom line, the idea that you have to go the IM injection of any volume at all, you want to avoid the deltoid, you want to go for either the glutes or one side of the thigh. So either lateral side or anterior side. So you should know this in terms of terminology. Vastus lateralis and rectus femoris. So the idea in terms of what one equals to the other should be part of your vocabulary. In terms of pediatrics, as to where you get it, the idea that glutes is always a good side. Dorsal glutes is also a good side. The idea in terms of overshooting, you can think about the deltoid. Again, you're limited by the body that you're going to give along the way. That's the downside to IMs. Again, glutes, you can do the rectus femoris as well.
Is the limit the same, the 5 mil limit?
Yes. So check this out. The idea that when we're using the deltoid, again, you're limited by 2 mils, okay? The idea in terms of you got a pretty good muscle mass off the deltoid itself. we're talking about the leg. We're talking about, again, a good muscle mass along the leg. You want to be careful in terms of move. That is that when we end up giving that, the idea that you imagine your hand up in their butt. The idea that there's a nerve that runs along here. What's that nerve? Yeah, sciatic nerve runs right along here. The idea that you go too much on the inward side, you end up with hitting the sciatic nerve. They will let you know about that in about 2.5 seconds. So coming up and just imagine that you're working in the outside horizon of this hip. And so you get into a median mass up there as well, and it works very, very well. So go ahead.
I've got a quick question on the thigh.
Yeah.
Can you back that slide?
Yep.
So the rectus, rectus femoris.
Right here.
And you're trying to aim for that point?
So what you're doing, Trevor, is you're just getting into this muscle mass along the side.
Oh, that's okay.
So the difference between obviously that sub-Q is 45 degrees, this is 9 degrees, and so you want to be careful with the length of your needle. If you end up hitting the bone, then you can chip a bone off of this and create its own issues as well. And so they can end up with an infection just that all by itself. So the idea of, let's back up for just a second here, the idea in terms of using nothing more than this, depending on the size of your patient, is max. So this is controversial in that it has pretty much gone by the wayside. You're still going to have a skill sheet. We're going to still sign you off on the skill sheet. The idea that you have to give medication down to ET. We talked a couple minutes ago about the possibility of bagging in albuterol or half ipratropium. But the idea that yesteryear we were bagging in atropine, we were bagging in epinephrine, we were bagging in Narcan, we were bagging in lidocaine has been important, yeah. So the idea that yesteryear was that because we could not get an IV started on these patients, this was our alternate means. What has replaced that? IO largely, but the idea in terms of also within there to a certain degree for whatever the drug is. And so to that, this is kind of gone by the wayside. Nevertheless, we show it here, we sign it off in terms of the possibility of consideration. Now, is it as effective as an IV push? Definitely not. I'm here to tell you there's no way. But the idea that you can't get anything else along the way, it's a consideration in terms of that possibility. The kicker is that whatever you put down the ET, you have to double it, sometimes 2.5 you dose. So if you're going with 1 milligram of epinephrine, you're going to go actually with 2 milligrams of epinephrine. Get back in there. Okay? Not effective, not great, but worst case scenario. Make sense?
Back to the putting in OG or MG2.
Yeah.
Yeah. If you've got a diabetic patient that's down because of hypoglycemia, you can't get a vein. Would you be able to put glucose down that milk or the bottom of it?
I can only give a mil. So would I choose to go a mil? I'd have to be real desperate in order to get there.
So would that be the rectal route coming?
I'd lay right near my glue down over that at that point. Are you guys okay? Need a break? Talk to me. Do you care right now?
Yes, but
no. Take your time. Come on back in 5 minutes. Yeah. Wednesday. Safe bet will be Wednesday. They may be posted before that, but we won't be talking about it.
I'll just keep getting good.
I'm trying to get this pause for you. Yeah, my cursor won't get there.
Let's do this. Escape.
Whatever works.
Where did your cursor go? There we go.
Well, yeah, so by the way, there was here.
Move on to the IVIO here. All right, so the other way of thinking about IV bolus, okay, IV bolus can be described as one of two things. IV bolus can be described in terms of a IV bolus is just exactly the way it sounds. That we're going to take some medication because that was the most common one. We talk about pre-filled epinephrine is the most classic one. Sometimes you will hear these referred to as Abrojets, pre-filled. Different things. When we talk about IV bolus, we're talking about an IV line. There's a number of different ports. And so, our thumb wheels up here. We've got it open and we're running everything like that. And this is connected to your patient. There's two different ports that sit right here. One is with a needle. This is the needle port. The other one is a non-needleless type port right here. Okay? So you can use it either way. The idea that we're trying to get away from using needle along the way is the whole thing about needleless port. Okay, so we're going to get rid of this right here. It's got a lure lock. You may not be able to see it from where you're sitting right here, but it's got a lure lock on that. So when we talk about an IV bolus, we're talking about the fact that we're going to push it into this, twist it, and lock it in place. So an IV bolus is that next step. And again, I'm not showing all the steps, but we'll do that tomorrow or starting tomorrow. The idea that we're going to pinch this off, that we're going to squeeze it into your IV is considered to be an IV bolus. So IV bolus is exactly this right here. So any drug that you're giving, as far as pushing it, is considered to be an IV bolus. So the other way of looking at that is an IV drip. Okay, there's 3 or 4 different drugs that we stand the possibility of getting. Dopamine being the most classic one. You can end up giving epinephrine, you can end up giving lidocaine, you can end up giving amiodarone, you can end up giving procainamide. Okay, so a number of different things. The difference being is that you're not pushing it in, you're hooking up another IV line, adding it into the line, and letting it run with it. Make sense? So piggyback is one thing in terms of fusion, bolus is something different in terms of pushing medication along the way. There's some that you end up pushing in terms of bolus. Lidocaine being a good example of that. You push lidocaine as far as bolus to get rid of the activity, the PVCs in the cardiac rhythm. Once that happens, you hold up a secondary line and you just keep flipping it in there. Okay? So the two work hand in hand in terms of what they're doing. Questions to that? Don't kill anybody with that. No, okay.
Just go straight to the chest, right?
It works on TV. It's got it. All right. So the we're going to play, and we're going to dig into especially the drip along the way. So both of them don't freak right now. Much more to come on. The good news about it is that it's a parenteral effect. So the idea that's going to hit this effect very, very quickly is a huge thing, which is good news and bad news. Good news and that if you get the appropriate dose, drug and everything else like that, has a quick effect. The bad news is sometimes giving that drug Let me give you an example. Epinephrine for somebody with severe anaphylaxis or severe asthmatic, the idea of giving 1 to 10,000 IV push is a real dangerous playing with a whole lot of dynamite. And so we'll talk about that later on in life. As with everything else we're talking about, with pre-filled or preloaded syringes, confirm your medication, patient allergies, confirm the pre-filled syringe is the right dose, expiration date we've been talking about, assemble the pre-filled syringe, pop off the caps. You can look like John Roy with that. Confirm indication, drug dose, and route of administration. Administer appropriately via the indicated route, and dispose of the needle syringe, and then follow up with your patient most certainly. So this is showing, this particular thing is showing a needle port right there. This is a Lorillot needle port. And again, this is just pinching up a line above it. And the whole reason for that, if you don't pinch it off, then it will go to the route of easiest, and that is it's going to go up through the line first before it comes back down. And one of the things I didn't mention afterwards is that you would go back to adjust your IV rate again following the medication. And a lot of times what we'll talk about is giving a little bit of a bolus with your IV line to get your medication in, and then backing off on your amount of IV fluids. And again, we're not going to camp here with piggyback, but just kind of talk about it. So I mentioned this, there's like 3 or 4 different drugs that you're going to learn as far as getting piggyback. Dopamine is probably the most classic one. Dopamine is probably the most classic one that you can hear about. Dopamine looks like that. And so it's pre-filled. So the good news is that most of you are going to carry pre-filled medications as far as your trips. However, in the off chance of having to mix it, you also want to have vials. Okay, so dopamine pre-mix, dopamine in terms of the vials that you have to mix your own. I'm not going to go through how to mix that today, but the idea that you can do both is one versus the other. This is more of a convenience in terms of making it like a whole lot easier for you. Okay? So when we talk about pre-mix, that's what we're talking about. In this case, what they're showing on the slide is that you have to do something wrong. So what they'll do is they'll pull up the dopamine, pull it up into the syringe. They are getting saline out, and so you're going to put dopamine into this bag. In the port issue. You put the dopamine into the bag, mix it up. You're hooking up the administration set, and you put this in. You're going to put this right into the primary line itself, dip it in. That comes a different day, much more detail about that. Questions to that? Or questions to anything you talk about?
You got some dopamine light sensitive?
Yeah, it is, as a matter of fact. Okay. That's part of the reason it's in the wrap. Okay. Nitro is another one that is like something. Questions? All right, stay in place.